In this case, we use a Davis-Boyle mouth gag speculum as the patient is edentulous and the usual bite block will slip. The hard palate anteriorly and soft palate posteriorly can be seen. One must be aware of the anatomy of the greater palatine neurovascular bundle when harvesting hard palate graft. It emerges from the greater palatine foramen, which sits alongside the second and third molars in the majority of people. The bundle runs in a groove between the maxillary alveolar ridge and the palatine bones. You may be able to feel this groove with your tongue where the vertical side of the alveolar ridge meets the horizontal hard palate of the roof of the mouth. The bundle travels anteriorly in the groove, giving off branches on its route and then leaving the palate through the incisive foramen, which is a single midline funnel-shaped opening immediately behind the central incisors. The hard palate has a midline raphe. The appearance of the raphe varies considerably from a groove to a ridge and even a significant bulge called torus palatinus in some individuals. The area of hard palate that will be harvested is marked. This is safely medial to the greater palatine neurovascular bundle. Medially, the graft does not reach the midline, as a relatively small graft is required in this case. However, if large grafts are required, it is perfectly safe to cross over the midline, although the midline mucosa is usually thinner, which may be less useful for reconstruction. Lignocaine 2% with adrenaline 1 in 1,000 is injected at the greater palatine foramen and at the incisive foramen to provide a greater palatine nerve block. Further anesthetic is injected through the graft area to improve hemostasis. The edges of the graft are cut with a number 15 blade. We then use an ophthalmic crescent blade to cut the base of the graft. We take mucosa and the underlying lamina propria. The thickness required depends on the indication. It can be taken down to, but not including, the periosteum. Vigorous diathermy is used to cauterize the donor site bed. An adrenaline-soaked gauze pressure pack is left in situ while the graft is used at the donor site. A hemostatic mesh can be placed on the donor site and left in situ to dissolve or fall off. Glandular tissue is removed from the graft as it can continue to secrete, which is not desirable, particularly in this case where the graft will be used for eyelid reconstruction.